unnecessary anxiety and manipulation. So in essence, if you're a doctor, if we are not giving this information like this to patients, we are basically, he's saying, is unethical. Are we willing to accept that as a society, as a patient? That our medical profession is practicing unethical medicine? Are we? I'm not willing to accept it. I don't think you are either, but you need to know about this. So let me give you a case study now. It gets a bit more interesting. So we'll move away a bit from the statistics because this is interesting now. So this can be any one of you guys or a patient, the doctors that are here that may have seen. So a 49-year-old man, he's type 2 diabetic, he has a heart attack. Now, if you're having a heart attack, then stents can be life-saving. I'll tell you exactly how life-saving they are later, but there is definitely some small benefit there from stents if you're having a heart attack. So he has a heart attack, he gets a stent, he's okay. He comes back to outpatients and he then reports after having the stent, I've got more pain, doctor. I'm having more chest pain. So I see this patient and the pain does not sound like it's coming from the heart. It sounds different. It's always there, constantly, which doesn't sound typical of cardiac pain. Maybe muscular, maybe something else going on. But because of his background history, we repeat his angiogram just to have a look, okay? And everything's fine. And we tell him everything's okay, and he gets sent home and given another pill for acid reflux. This could be acid reflux, could be stomach acid. So we'll give you this pill, you take this, and hopefully things will get better, and we will see you again in the outpatient clinic in a few months. He comes back to clinic. He comes back to clinic with his wife. I see him. He's depressed. He's now depressed. He said, doctor, my pain, he's an Indian man, my pain is still there. I'm having for 3 months. Wife is getting worried. He's going to depression, constant pain. Imagine this. Living every day, just pain constantly in the chest. So I looked at his drugs that he was taking. And one of the drugs, and I thought maybe this is, he was also telling he had muscle aches. I thought maybe this is a side effect of statins. He's on a statin drug. So I said, listen, let's try you off the statin. Just stop it for a few weeks. I'll write to your general practitioner. And if the pain doesn't go away, you take the statin again. If it goes away, we think about something else. I wasn't sure what was going on, but I thought, let me try the statin. Now, he's given an appointment for 3 months later. Okay? We write the appointment for 3 months later. 1 week later, he comes uninvited, without an appointment, to the hospital. I'm doing the clinic, and he knocks on the door, and he comes in, and he says, he's very happy. He's very happy. He says, thank you, doctor. After months of misery and pain, my pain has gone after stopping the statin. But now I'm worried, because my doctor said you must never stop your statin or you could die. Now, can anybody here guess? Let's see. There's a bit of audience participation now, right? Can anybody here guess what the risk of him dying is from stopping a statin? Statin is a cholesterol-lowering drug used for treatment of heart disease. I'm sure most people know about this drug. What do you think, he's had a heart attack, okay? What do you think his risk of dying is from stopping the statin for 2 weeks? Any guesses? Somebody said 1 in? 183? Somebody said 0? Okay. Any other takers? 1 in 16? 1 in 1600, okay. It's actually close to 0. It's about, if you look at the statistics at face value properly, it depends how long after the heart attack it is. If it's within the first 4 months of having a heart attack, there's no risk of death at all, 0. The benefits only start a little bit later on. If it's later on, it's about 1 in 10,000. It's essentially close to 0. But how many doctors, will tell you this? Stop your statin, you could die. We've all got to die at some point. But what are the chances? Very, very small. Okay? So this is, again, misinformation. Doctor is misinformed. Doctor thinks they're doing the right thing. But this is fear-based. It's not actually looking at the data, the science. Okay, let's talk about cholesterol now. So again, for a long time, for many years, we have been told that, or certainly the cholesterol has been the most important risk factor, or considered to be the most important thing we can do to prevent heart disease. Okay? And I'm not here to say that cholesterol is not involved in heart disease. It is, but the actual Our approach to managing cholesterol is wrong. It's caused harm. And if you look at the original data from Framingham, so this is where we looked at population in Framingham in the United States, followed up 5,000 people over several decades, where we picked risk factors of people who are going to develop disease, high blood pressure, cholesterol, smoking, etc. When you look at the original data in Framingham, unless your cholesterol was very high, it was not predictive of who was going to get heart disease or who wasn't. And in fact, this is written by the co-director of Framingham, published in Atherosclerosis in 1996. Let's talk about LDL. LDL is considered bad cholesterol, right? Low density lipoprotein cholesterol is considered the bad cholesterol. Unless it was above 7.8, he wrote, it is virtually useless at predicting who's going to get heart disease or not. Now, how many people here have an LDL above 7.8? You know, most of these people are people who have a genetic abnormality with something called familial hyperlipidemia. But the overwhelming majority of population, more than 95%, maybe more than 99% of the population, do not have LDL anywhere near that high. Yet we're bringing the cholesterol LDL down. Question is why? If you look at the association, it's only if it's above 7.8. And actually, when you look at the data in totality, the better predictor is your total cholesterol divided by HDL, the good cholesterol. That's what is used in our risk score calculations, not LDL cholesterol. That is across all age groups, across both male and female. Now, when we think about heart disease, it's important to put things in perspective, okay? Because it's about a hierarchy. Not everything is the same. Some things are more important, more predictive than others in terms of what is the number one. What should we be focusing more on than anything else? And this study done in diabetes care looked at the different risk factors, and they actually found that if you're going to prevent heart attacks in young adults aged between 20 to 30, then the most important thing that people can do is to target insulin resistance. So it said if you prevent insulin resistance, which is basically the body becoming resistant to the hormone insulin over time, which is what is the precursor of type 2 diabetes, that would prevent 42% of heart attacks. The next most important risk factor was high blood pressure, which is a big problem in India and across the world at the moment. Then it was having a low HDL cholesterol. Then it was body mass index. LDL is near the bottom, 16%. So LDL, and that too probably in people with very high LDLs. So LDL is much lower down. Insulin resistance is the most number one risk factor. But we haven't got any drugs that target insulin resistance. There's no market for the message of insulin resistance, even if it's the most important risk factor. And that's why most people don't know about it. But guess what? What is the best dietary approach to target insulin resistance? Low carb. Low carb diet is the best way to tackle insulin resistance. Because this is carbohydrates, especially starchy carbohydrates, have the biggest impact on glucose and insulin. Of all the different macronutrients we consume, fat, protein, it comes from starchy carbohydrates. So, that again is information that most people don't know, because there's no market. Who is going to profit from that message? Which company profits from that message? Now, let's move further forward. We talked about LDL's risk in the young people, right, of heart disease. What about in older people? So I was involved in this systematic review, and we found that if you are over 60 years old, LDL cholesterol has no association with heart disease. It has no association with heart disease. And not only that, we found that it was inversely associated with mortality. In other words, the higher the LDL, the less likely you are to die. The higher your LDL, if you're over 60, the less likely you are to die. And how is that? Cholesterol has many vital functions in the body. Without cholesterol, we would die. It's produced by the liver. It has a lot of functions. It's involved in hormone synthesis, vitamin D metabolism, precursor. But it also has a role in the immune system. And elderly patients, certainly in the Western world, are quite vulnerable to infections, pneumonias, gastrointestinal infections. So elderly people are more vulnerable to infections, and it seems that it may be that this is protective. But certainly there is no association with heart disease. And I've had patients come to me. I remember seeing a 65-year-old woman in my outpatient clinic in the National Health Service in the UK who came in, and she was looking scared. She came in scared. She came into my cardiology clinic and she says, "Doctor, I'm very worried. My GP has done my cholesterol and I've been told it's high. I said, congratulations. I said, congratulations, you're going to live longer. And I explained it to her and she was very happy and she left the consultation room and I wrote to the GP and explained this. Now, statins, the most prescribed drug in the history of medicine, prescribed for well over 2 decades. And in 2013, Dr. John Abramson from Harvard and colleagues wrote a review of the data that was already published, drug company sponsored data, just reanalyzing the same data, looking what was published, to see, do statins benefit people who do not have heart disease? Because that's most of the prescriptions, 75% of people who are taking statins around the world, and we think about 100 million people probably are taking statin drugs. Most of those people fall into this category. They don't have heart disease and they're prescribed a statin. Do these people have any benefit? Do they live any longer? And what they found is there's no prolongation of life. You're not going to live 1 day longer from taking a statin. And there was a very small chance it would prevent a non-fatal heart attack or stroke. He estimated about 1 in 140 from this data that was still industry-sponsored data. So I would argue this is still best case scenario, but definitely no prolongation of life. And what he says is, listen, the problem we have in the Western world now, and around the world actually, is chronic disease, heart disease, type 2 diabetes. And the best approach really for these people who have been calculated to be in this low risk category from different risk factors of heart disease is we should do lifestyle. And he also mentions this. He says 80% of heart disease is related to environment and lifestyle. So this is about smoking, poor diet, lack of activity, stress. These are the things. Now, the other thing, this is where the real controversy happened. And I was involved in a big controversy now, which I'll talk about, and what happened here, is John Abramson and myself, both of us, at the same time, I wrote a commentary, an article review. I didn't do the analysis of the research, but I looked at data myself. I wrote a commentary about saturated fat. People think saturated fat from foods like butter and ghee and cheese is going to cause heart disease. I wrote a review saying there's no link, no strong link between that and heart disease. And in fact, we should be focusing on sugar. Sugar is the problem. So in the same issue, I wrote an article, but I also talked about statins. I said, this mass medication, millions of people are taking statins, they're not going to benefit. And in the same issue, I also said what John Abramson said, is that statins cause side effects in about 20% of people. That was my own experience. That's what I believe to be a real world data told me, is that around 1 in 5 people taking statins, it's quite a lot, get unacceptable side effects. Okay? And these include muscle aches are the most common. Lethargy, feeling tired, muscle aches, but even for men, erectile dysfunction, memory disturbance. These are the list, stomach complaints. And I was seeing a lot of patients I had seen as a cardiologist. I've treated probably well over 10,000 people in my career. And I was seeing more patients coming in, and it was side effects of statins was an issue. And what I was seeing in my clinic did not match the clinical data and published in the medical journals, where they were saying this is probably less than 1% to get any of these symptoms. In fact, they talk about serious side effects, 1 in 10,000. But anyway, so this didn't make any sense. So I said, we need to change this. There's something wrong here. This is biased information. This is not correct. And we shouldn't be giving more statins to more people. And this is what I wrote in the British Medical Journal. I'll come back to statins in a minute. Let's talk about saturated fat, because even yesterday in the press conference, I think there is still this mistaken belief out there that eating fat causes heart attacks, goes to the arteries and causes heart attacks. And it's completely and totally false. Forget about fat, specifically saturated fat. So this all came about because an American scientist called Ansel Keys, who carried out a study called the 7-country study, published in 1970, he correlation between saturated fat consumption in several countries and heart disease. But we found later on that correlation, he'd left out for whatever reason. There were other countries that weren't put into the data. And when you add other countries in, that correlation seemed to lessen or almost disappear, as much less. Not a significant correlation at all. But actually, for whatever reason, maybe it was sugar industry involvement, political reasons, he was very passionate what he believed in, and he pushed this in a very aggressive, assertive way. Is this his research? Because up till about 1950, 1960, there was a massive increase in heart attacks happening in the UK and Western world in America. And doctors are trying to work out why. Now, at that stage, they didn't realize how bad smoking was. In fact, if you go back to the 40s and 50s, I mean, there were commercials, where doctors were even, advertising cigarettes. It was not uncommon to walk into the consultation room. Can you imagine? Where you're going to see your doctor, and the doctor is sitting there smoking a cigarette. Okay? In those days, we didn't realize how bad it was. So this wasn't emphasized very strongly. And I think that was one of the problems. And they're trying to figure out why there was such a big increase. But saturated fat was put as public health enemy number one. And it resulted in a change in dietary guidelines in the UK and the USA in 1977, 1983, which specifically said we should eat less than 30% of our calories from fat and less than 10% from saturated fat. Now, what did that mean? In essence, that then meant we were going to be advised to increase carbohydrate consumption. Not just that, you see, the industry would respond. If this is a national government guideline, industry selling sugary foods or whatever else would then start marketing low-fat foods, which were high in sugar. So this is what the consequence was. And this then resulted specifically in particularly refined carbohydrates, sugar and the floury-based products had a big increase as being heart healthy. Low fat, no saturated fat, heart healthy. Bread, pasta, potatoes, white rice, sugar. Sugar doesn't cause harm to the heart. That's what this was the message that was given. And we've seen, as a consequence, certainly we know this, we have a massive problem now of type 2 diabetes and obesity. Not just in the developed world, but in developing countries as well. Not just in older people, but younger people. We're seeing more and more type 2 diabetes. And in my view, the root cause, or one of the major root causes behind this, is this wrong dietary advice. This is how this low-carb movement has really come from this realization that we've got it wrong. We also know, now I don't know how much of a role this played, but I learned relatively recently that Ansel Keys, a scientist, also received research money from the sugar industry, the very powerful sugar industry. But let's talk about the science now a little bit. Let's talk about the biology, okay? So what does the data tell us about saturated fat and the effect on cholesterol? So I've said to you earlier that I don't think cholesterol is that important, but let's say we accept cholesterol is important. Even then, saturated fat increases good cholesterol, HDL. It has a very small impact on LDL. In fact, recently a study showed even coconut oil had almost no effect on LDL and increased HDL. So in theory, coconut oil could be cardioprotective. Can you imagine? And people are demonizing it and saying it's harmful. It could be cardioprotective. We don't know, but it certainly doesn't seem to cause harm. So what it does is it increases HDL. Even if it was to increase LDL, remember at the beginning I said the most important risk determinant is not total cholesterol or even LDL. It is total cholesterol divided by HDL ratio. So the impact on cholesterol ratio is minimal, if not at all. Okay, so that's the biology of it. And also there are many different types of saturated fat. Again, this is a misunderstanding amongst academics, even nutritionists. There's a lack of appreciation that saturated fat in red meat is different to saturated fat found in dairy, different to other sources of saturated fat. Now, something interesting as well, we have been told for a long time that consumption of vegetable oils, sunflower, safflower oil, corn oil, soybean oil, proven to lower cholesterol, is healthy. Sorry, it's not healthy at all. We know even if you fry in these oils, common frying purposes, I'm staying in a hotel not far from here, and in the morning I go and have my breakfast, which was, I asked for omelette. But I said, how do you cook it? Sunflower oil, sir. Sunflower oil? No, thank you. Not healthy. Cook it in butter for me, please. Ghee or butter. If you heat these oils, even for common frying purposes, they produce these compounds called aldehydes. which are toxic, and even the World Health Organization recognizes it as being a carcinogen. There is a scientist in the UK, a neuroscientist, who believes that one of the causes, or one of the major causes of increase in dementia, people developing dementia, is through the consumption of these oils, and they're rife across the Indian subcontinent. But anyway, I'm coming back. So what interesting study, they did a reanalysis of a study that was published called the Sydney Heart Study, where they did a randomized trial where they gave patients with heart disease butter, and in the other group they gave them safflower oil, which is one of these types of oils, high in omega-6 fatty acids. Now this is interesting. In the patients who had heart disease who took the safflower oil margarine, they had a 13% reduction in cholesterol. So think about this. At the end of the trial, the ones in the safflower oil group had less cholesterol reduced by 13%. Sounds impressive, but they had more death. So the group that had the cholesterol lowered had more death. And it's thought that it's because this is a pro-inflammatory oil, pro-inflammatory product. Because inflammation is the issue. Heart disease is a chronic inflammatory condition, and it probably or certainly seems to be linked to the fact that it was pro-inflammatory. Another interesting reanalysis of the research published by Cambridge Medical Research Council actually looked at consumption of different fats across the world, and were very interesting. They found that these polyunsaturated fats and oil, there seemed to be no benefit in reduction of heart disease. But one interesting finding is they found that a particular saturated fat called margaric acid, which you find in dairy and butter, the consumption of that seemed to be associated with less heart disease. Now, I've said to you before, association doesn't mean that it's a cause, but it's an interesting finding, and certainly doesn't seem harmful, that dairy potentially could be protective. So really, I think what's important is we should think about foods rather than focus on this saturated fat. We should think about whole foods. What foods are people eating? How is that part of a healthy diet? What kind of nutrition are you getting from it? What does the data tell us? Is there some benefits? That's what we should be thinking about. And the problem is, a lot of low-fat foods that have been marketed, and still now, I'm sure even in India, are loaded with sugar. So what happens is people are buying, because the food industry are not there to look after your health. They're there to sell food. They will promote things to mislead people to buy these products. Because most people will buy a product on the way that it's marketed, not the actual nutritional content. So many low-fat foods actually have been loaded with sugar. Low-fat yogurts, for example. Some of them in the UK, they had 7 teaspoons of sugar. And people are buying them because they think it's healthy. How misleading is that? It'll have the opposite effect on your health. So imagine the scenario, you're going there, you want to buy something, it looks healthy, low fat, low cholesterol, and it's causing you harm. And you are buying it with the intention to do good to your health. This is unacceptable. So let's come back to the statin controversy. So Professor Sir Rory Collins, who is the co-director of the Clinical Trial Service Unit in Oxford, a very eminent professor, he had been involved in a lot of the original statin trials, and his department, his organization, his group, they have commercial agreements with the drug industry that they cannot release the raw data on statins, so that can be reanalyzed. In these trials, what happened to individual patients? There are lots of information on individual patients that we need access to, and they basically have those agreements. So when this publication happened in the British Medical Journal, it became widely publicized. In fact, I was on, it got press released, talking about saturated fat. I was on Fox News, CNN, it was main BBC News headline saying cardiologist says saturated fat is a myth. But also, some of the other news reporting suggested about the statin side effects. So a few months later, he actually was not happy. He said the side effects are very uncommon, and he was worried that people who have high risk of heart disease or have heart disease will stop statins unnecessarily because of the media scare stories, and this would result in people dying. And he actually said in The Guardian, and he called for retraction. He said this article should be retracted, both of them. John Abramson's and mine, we said 20%. He said they should be retracted. And he wrote to the editor of the British Medical Journal, Fiona Godley, and she said, no, we're not going to retract them, but we will publish your critique, and that we can then judge from there. He refused for some reason not to write a critique. Most academics would jump at the opportunity. Somebody said something I disagree with, and you were giving you a full page to write your critique in the medical journal, but he didn't want to do that. He just said retract. He said we can't do that. So then he went to the Guardian newspaper, or the Guardian went to him, I don't know. And this is what, it's important to remember what he said. This is a chap who's the leading research, if you like, on statins. And he said, there are only 1 or 2 well-documented side effects. Myopathy, which is, or muscle weakness, occurred in 1 in 10,000 people. So listen to this for a second. We're talking about 1 in 5 people having unacceptable side effects. He's saying 1 in 10,000. There's a big difference, right? That's what he said. The controversy then continued because this didn't make any sense. Our national guideline board in the UK, NICE, the health watchdog, came out with guidelines for doctors despite the evidence showing, and he didn't disagree with the lack of mortality benefit. He did not, Professor Collins did not disagree that patients at low risk of heart disease would not live longer. Okay? He didn't disagree with that, but he said the side effects were exaggerated. But despite that, our national guideline body came out with new guidance saying that actually we should be giving statins. Doctors should prescribe statins to people who are low risk of heart disease, healthy people. They came out with guidance. And what that would also mean is doctors would be financially incentivized, because there's a system in the UK that's being changed now, but you have targets. Doctors have targets. You have to get so many people on statins, so many people on blood pressure drugs who come into certain categories. They'll be, again, unethical. It takes away the patient preference because most people are not going to benefit. So this was going on, and myself and a number of colleagues, including the Queen of England, former physician, Sir Richard Thompson, wrote a letter to NICE, and we again press releases. We got hold of journalists and said, listen, this is really, a lot of leading doctors are going to oppose this. We don't think this is a good idea. And we said there was a lot of problems. We said the guidance of this panel of experts who are the authorities telling doctors what to do, most of them had financial ties, either institutional, personal financial ties to the drug companies who make statins. This is not independent. We said that it will not help people in the population. Millions more people who take statins. There's not going to be a reduction in death rates. We said more GP appointments, more stress on the system. We also know statins cause type 2 diabetes. That's now accepted, that 1 in 50 to maybe 1 in 100 from taking a statin will get type 2 diabetes just from the statin. So that's also now, we found out after 30 years, this is what it does. So we said this is not a good idea. It will cause overall harm to population and public health. But despite that, it did have an effect. NICE then, the guideline health watchdog, withdrew its recommendation for this low-risk people. But then what happened, 2016, the Lancet Medical Journal with Professor Rory Collins then published another review. They said, okay, we're going to look at the data again about the side effects. So they published another review. These are the same people who hold on to the data of commercial agreements whose institute has taken over £268 million in funding from the drug company manufacturing statins, who are telling us to take more statins. They said, oh, the side effects are not. We've looked at the data again. There isn't much on the side effects. Looking at the same data, which we think is biased, to say the same thing. Okay? So they published a review in the Lancet and said, listen, let's put this to bed now. We want no more debates about statins, no more discussion. It's a great drug. Everybody, most people should be taking it safely, not a problem. So they published this review, and that became a big news story. But this is very interesting. What happened next was very interesting. I think you couldn't make it up, what I'm about to tell you. The Sunday Times newspaper, about a week later, did an investigation. And they found out that Professor Collins, who said that side effects were rare, he then said in his review maybe 1 in 51% of this muscle ache symptoms. He is a co-inventor of a test. He has a patent on a test that tells you whether you're likely to get muscle pain from statins. The test, which was branded as Statin Smart, was being sold in the United States for $99 each, directly to the public, on a website that says 29% of people taking statins will suffer muscle pain, weakness, or cramps. And the marketing material also said that 58% of patients on statins stop them within a year because of muscle pain. Can you imagine? Why are the patients stopping their statins if their side effects are rare? It doesn't make sense. But this is also bizarre. Professor Collins, who said side effects are rare, had invented a test. There's a blood test that tests for a gene that tells you, 1 in 4 people have this gene, that whether you're likely to get muscle pain from statins. And it was being marketed saying 29% of all people get side effects. And it says that royalties in the investigation, it said royalties from this patent, from licensing of this patent, can be used to fund university research. Professor Collins had said this was misleading. So they'd asked him for his view on this. And he said this was misleading that they were doing this. Okay? But clearly money had been received. But what was interesting is the Boston Heart Diagnostics, the device company that was selling the product on behalf of, and giving the royalties to Professor Collins and his department, they said they stood by its claims. And they said that a US task force on statin safety said randomized controlled trials, such as those used in the Lancet study led by Professor Collins, had major limitations because patients with statin intolerance were often excluded. So what often happens in a trial, drug trial, is they start, in the first several weeks, they put people on the statin. And people who are non-compliant, they say, basically get side effects, are taken out before the trial starts. In one trial, the heart protection study, 36% of patients who were originally enrolled were removed before the trial started. So think about that. You're now getting information on a selected group of people who didn't get side effects, and then reporting in those people saying side effects were less. So that helps explain to some degree why there's a discrepancy. The Sunday Times then did a Freedom of Information request to Oxford University. Did you receive any money from the sale? Because it's a bit strange, he'd launched a public campaign, side effects were rare. Did you receive any money from the sale of this test, saying 29% of people get side effects? And if so, how much? And they did. So this is a Freedom of Information request that the Sunday Times journalist, chief reporter, was happy for me to share with you, that he asked. It's not been reported on any mainstream media, but basically his department received over £369,000, the university, and he himself and his department, 120, he waived personal fees, but his department where he works, where he's a co-director, received £126,000 on the sale of this device. It's extraordinary. Very puzzling. So what about statin data in the population? So we talk about this randomized controlled trials, drug industry sponsored, problems of bias, how can we believe the data? We have ways of looking at data in the population to see, have statins actually reduce mortality in the population? And this was carried out published in the BMJ Open, looking at European countries over a decade to see, was there any clear link between increased use of statins in different risk groups, including people at high risk of heart disease? Was there any reduction in death rates, cardiovascular, and there was none. So think about all these millions of people taking statins, but in the population, when they looked at the data, there was no link between use of statin increase and reduction in death rates from heart disease or overall death. Now, let me give you another way of presenting the statistics. We've said that in people at low risk of heart disease, okay, there's no life years, there's no gain in terms of lifespan from taking a statin, yes? But I said that there is some small benefit in people with heart disease. But if you look at the statistics differently, and you go to your doctor, and you say to your doctor, doctor says, take the statin. You will live longer. Take the statin. What if you said to the doctor, how much longer will I live? How much longer will I live? There was an analysis done, I'm going to show you in a second. If you're taking a statin, and let's not, we know that it's not a mortality benefit in people at low risk, but if you're taking a statin, you've had a heart attack, okay, where we think there is some benefit. If you look at the statistics in a different way and try and calculate the average increase in life expectancy in the group of people taking statin who've had a heart attack, what would you hope to achieve over 5 years? You've had a heart attack, doctor says take the statin. How much longer would you hope to add on to your life over a 5-year period? How many extra years, months, whatever? What would you hope for? What do you think? Any guesses? What would you hope for? How much longer? What would you want? You've had a heart attack, you've survived the heart attack, doctor says take a statin religiously every day without fail. Over a 5-year period, how much more would you hope to add onto your life? No, but say that if you take all of the group, say middle-aged, 50s, 60s, whatever. Well, another 10 years, okay. This gentleman here said he would hope to add an extra 10 years taking a statin every day for 5 years. Anyone else? You know the answer already. The answer is 4.1 days. 4 more days longer. How many patients are told this? How many doctors know this? Now, what about cholesterol reduction? We think that the trials tell us lowering cholesterol with drugs is going to benefit you, but actually what is missing? So one of the problems of this misinformation is you've got good quality data, but if it doesn't suit the interests of industry, it doesn't get well publicized. It doesn't get well publicized in the media. If it doesn't get publicized in the media, people don't know about it. But I'm here as a doctor, as a scientist, to try and look at all of the data and try and come to a conclusion about whether lowering cholesterol with drugs is beneficial. And actually, there are 4 dozen randomized controlled trials, actually, and they were industry-sponsored trials predominantly, who showed there was no reduction, most of them no reduction even in heart attacks by lowering LDL cholesterol, and no reduction in death rates in any of them. Yet this is not well publicized. Because as a scientist, you see, you don't just rely on one study, you do many studies, and then you come to a conclusion of whether something, because sometimes you can get a positive result because of chance. It could be chance. That one study by chance. It wasn't because actually the drug helped people, just by chance. So you have to do more and more and more and look at the reliability. And this suggests that cholesterol is not, as we've already said, is not as important as we think it is. And certainly lowering cholesterol by diet has never been shown to be beneficial. That's the other thing. Even though statins show some small benefit in people with heart disease, lowering cholesterol by diet has never shown any benefit whatsoever. Like just lowering LDL by reducing saturated fat, etc. No benefit at all. Heart attacks, strokes, death, nothing. So what is this unintended consequence? Not just about what the data tells us. Think about this for a second as a concept. Focusing on LDL reduction, you get statin drugs prescribed to millions of people who are otherwise healthy. Some statin users think they can eat what they like. Because my cholesterol is okay. I'm taking a statin. My diet must be good, or I can eat what I like. I can eat any kind of junk food. I've got a statin pill. This is a mistaken belief. Because the statin, they don't know the statin is not going to prolong their life, and then they're eating junk food, they get type 2 diabetes, which will shorten their life by average reduction in life expectancy for type 2 diabetes is 5 to 15 years. People will live on average 10 years less if you have type 2 diabetes. You then just have this problem of low-fat foods being promoted, which actually then increases the risk of heart disease. And it's also distracted us from other strategies. Because we just focus, the doctor is focusing on lowering cholesterol, not talking about lifestyle, not talking about low-carb diet, not talking about good exercise or meditation or stress reduction or good sleep. You know, this is a distraction as well from more important things. This picture speaks 1,000 words. He's quite happy to eat. Oh, I'm taking a statin. Yeah, let me have the fries and the burger. But this exists. I've seen patients who believe this. This exists. This is a problem. This is harmful. We're causing net harm to this individual because of the mistaken belief of statin protection. So another case study is very interesting. Case I will share with you. That's a bit of water. So a 55-year-old man who I saw. And again, he's happy for me to share his name. There's no breach of confidentiality here. Tony Royal. International airline pilot with Virgin Atlantic. Okay? Age 50. And he's very active. Exercises a lot. We're doing triathlons. I mean, really active guy, but not watching what he's eating. Low fat, high carb diet, sugar. Not the worst diet, but still not great. And he basically gets a routine check in September 2014. He's overweight, his BMI is 28, waist circumference is 38 inches. And his total cholesterol is 6.4, and his ratio is 5.3. The higher the ratio, the higher the risk, okay? He gets assessed, and he's given a 12.86% chance that he's going to have, he could suffer a heart attack or stroke in the next 10 years. We know that if it's less than 20%, he's not going to live any longer from taking a statin. But then, sadly, in December 2014, luckily not while he was flying a jet in one country or when he came back, he got a bit of chest pain. He went to his doctor and got evaluated. And he actually had a small heart attack. And he had a small heart attack, and one of his vessels was completely blocked. So they opened it up with a stent. That's fine. So they opened it up with a stent. His left ventricular function, heart function was good. There wasn't any significant damage, but he's now had a heart attack. And guess what? Typical heart attack, 5 pills, aspirin, clopidogrel for the stent, statin, beta blocker. He gets put on all these pills, right? And he's thrown out of the hospital. You know, he's not thrown out, but he's like, right, on your way. This is what we do, right? We do cardiologists, we do the stent. Take your pills every day, otherwise you will die. Go home. So that's it. That's the conversation he has. And basically, about a year later, so this is the pills he's on, he suddenly starts feeling very unwell. He's got lack of energy, lack of drive, erectile dysfunction, dry skin, speech, his mental acuity is going. This guy, by the way, because he had a heart attack and he's an airline pilot, he can no longer fly. The rules are he can no longer fly. He was originally a maths and physics teacher. Okay, so this guy is a clever guy. He goes back to teaching high school kids maths and physics. So he's very good with statistics, very intelligent guy. He gets all of these problems. He can't exercise very well now. He's getting tired. So he himself, without speaking to his doctor, reads up on the literature about the side effects, the benefits of statins, everything. He works it all out himself, everything I've told you. He works it out himself. He realizes there's not much benefit here and this may be giving side effects. So he decides of his own to stop the pill. Okay? He stops the statin and the beta blocker, and within weeks of all his symptoms get better. Within weeks. There's erectile dysfunction, memory problem, energy. He feels like a new man. I'm not going to take these pills again. He also, at the same time, starts reading about low carb. He starts reading about low carb and ketogenic diet. And he thinks, okay, listen, I'm going to change my lifestyle. Let's see what happens. So he basically cuts out sugar, cakes, biscuits, juice, starchy carbs, increases non-starchy vegetables, oily fish, eggs, full-fat dairy, nuts, berries. He changes his diet completely. Within 3 months, he's lost 3 stones in weight. So that's about 15, 16 kilograms. He's lost in weight in 3 months. And he's not increased his exercise. In fact, he's reduced it. His waist circumference has come down. His cholesterol's gone up. His total cholesterol's gone up, but the ratio is better. Remember, the ratio above was 5.3 and the previous one is now 4.4. So his cholesterol profile has got better. Now, this is also quite interesting for me. He then comes to see me privately. Okay? He's read about my work, what I've been doing. And he comes to see me because he trusts me that I'm going to give him the information correctly. He wants to see, am I doing the right thing here? By the way, I've got to tell you something else interesting. In this period of time, he stops all his pills. He stops his aspirin. I'm not saying you should do that, but he made an informed decision. He stops all his pills. He's had a heart attack. He's not taking aspirin, statin, beta blocker. He stopped everything. And he feels in the best shape of his life. His blood markers are excellent. And he comes to me to have a discussion. What should I be doing? Is this okay? He wants reassurance because obviously you're going to have a bit of doubt whether it's the right thing. I say, listen, maybe you should go back on a low-dose statin. You will not get side effects. You might have a benefit. Take aspirin as well. But I said, it's your decision. You can look at the data. I discussed it with him. And he calls me up 2 weeks later and he says, no, you know what? I'm feeling so good, doctor. But actually, the reason he comes to see me, he wants to do Ironman now. Ironman, which is very extensive exercise. It's running a marathon. It's a 100-mile bike ride. And it's swimming 10 miles all in one day. It's pretty extreme, very vigorous on the, and he's a middle-aged man and he's had a heart attack. I said, listen, I don't think you need to do this, but if that's what you want to do, then fine. But, you can get just as good benefits for your heart health by doing less exercise. Anyway, I wrote about this in a medical journal. I thought it was a very interesting case. And to highlight also about the transparent, about the ethical approach to medicine. The first slide I showed you about patient preferences and values. This patient decided at that time that he did not want to take pills. He wanted a lifestyle approach, and that was his choice, and he would accept the consequences of that, and that's fine. So we wrote about this, me and the chair of the Medical Royal Colleges, not just myself, but the most authoritative, one of the most authoritative doctor in the UK. We wrote about this in a medical journal, got press released, and this was the Daily Express and the Daily Mail. And this was the headline, front page, ditch pills to beat heart disease. Going again, trying to push that message, guys, we need to focus on lifestyle. This guy's doing very well. This is what can be achieved. if you go for the lifestyle approach. People can do both, okay? But this is an interesting case. So let's talk about the problems with drug industry-sponsored research. Now, Peter Wilmshurst, who's a cardiologist in the UK, he gave a talk in the Centre of Evidence-Based Medicine in Oxford, and he made some very interesting points that I took on board and made me think very differently about why we have this system failure in medicine. He says drug companies and the medical device companies, they have a legal obligation as businesses to make a profit and declare shareholder dividend, but they do not, surprisingly what we'd think, they do not have a legal obligation to give you the best treatment. But he says the real scandal is that regulators failed to prevent misconduct by industry, so data manipulation, fabrication. They failed to prevent misconduct by industry, and that doctors, institutions, and medical journals that have responsibilities to patients and scientific integrity collude with industry for financial gain. That is the problem, because we know that the industry is there to make money, but who is guarding, who is protecting the public from these excesses and manipulations of industry? And he gives a submission to the Parliament, actually, giving lots of examples in the UK. So we say this is a concept. What is the evidence? People say, well, what is your evidence, Dr. Malhotra, about this going on? About research misconduct? It's extensive. The evidence is pretty extensive in the UK, certainly. One of the reasons is these academic institutions, they have a pressure. If you're a scientist, an academic in a big institution, such as Oxford or Cambridge or Harvard, you're under pressure to publish for advancement of your career. In fact, the primary motive is not money for the academic, it is prestige and power. Most people in medicine go into medicine not because they shouldn't be going in to make money. I mean, we have a good living, but it's primarily to help patients. So it's for prestige and power in their institution. It helps them gain career advancement. And if they get good publications in journals, they're likely to get more funding, often from the drug industry. And then that carries on. And you're in the department, you're getting all this money coming into the department from an industry, going to sponsor you doing a trial. Everybody's happy. Other pressures also come from of misconduct come when when people have patents or shares in particular devices where they're going to actually receive money, personal financial gain from it. And what he says is this. I mean, he's very candid in the way he describes this. And this is actually, so this is taken from a publication to Parliament. I mean, he was very precise. He says some publications, some medical journal publications are simply organized criminal activities, which may be at the behest of the sponsors when prominent academics are paid large sums of money to publish false data by industry, or a sponsor may be one of the victims when payments for conducting research are made to investigators who simply fabricate data. Some publications are simply organized criminal activities. Why? And the medical journals also have a financial pressure to publish because they also receive a lot of money, from reprints of papers. So I remember as a doctor going up, in hospital medicine, we'd have these lunch meetings with drug reps, and they'd come to talk to us about a new drug, and they'd come with their, maybe the Lancet or New England Journal of Medicine, a reprint that would give us for free, okay, of the article of the paper to read about this drug. Now, the drug companies pay lots of money to medical journals. Once they get it published, they then pay the medical journal, sometimes hundreds of thousands of pounds, say we want, 10,000 copies of that reprint from your journal. We send it to you, then they give it to their pharma reps. The pharma reps go around to the hospitals. They go to the doctors giving this up. It's just marketing material. It's essentially marketing material. So this is again a problem. It's a system problem. The journals why are the journals publishing it? There is money to be made. Also, the journals like publicity as well. So to protect their reputations, academic institutions conceal research misconduct, destroy evidence, and silence whistleblowers. So one of the other problems is, in the department, if you have people who are aware that think this is wrong, why are we fabricating data? They will do what they can to silence those people. They don't survive very long. Richard Smith, former editor of the BMJ, wrote in an article that he is giving a talk to academics from different places, and he asked the audience of professors, how many of you in your career have been aware of someone in your department committing research misconduct? 1/3 to a half of the audience put their hand up. He then said, how many of you reported it? Everybody put their hand down. Journals are often reluctant to admit that they publish flawed research, and also there's an issue of libel action. If somebody accuses somebody and the evidence isn't strong enough, even though it's clearly been a problem, then exposing research misconduct can be quite difficult. So he says, what is the best way that we address this problem? He said we should make these forms of research misconduct criminal offenses. I mean, he's talking about meaningful sanctions, even people going to jail. That doesn't happen. Now, just to give one example of research misconduct, one Dutch researcher had essentially been found guilty of manipulating data suggesting that beta blocker drugs could be beneficial for people undergoing non-cardiac surgery. And it was found out after many years that this data didn't make sense, it was wrong. And it was then analyzed and suggested that because of this research misconduct, up to 800,000 people died unnecessarily. 800,000 people died across Europe over a period of number of years. 10,000 suggested in the UK. Can you imagine that? Some research misconduct goes into a medical journal, becomes a guideline, doctors then prescribing the pill in this situation, and people, because of the complications of taking the beta blocker around surgery, there were excess deaths. It's pretty extraordinary. This is something we know about. What about things we don't know about? Peter Gosha, the co-founder of the Cochrane Collaboration, prestigious independent scientific body, he basically says that what we need, and his estimate is prescribed drugs now is the 3rd most common cause of death after heart disease and cancer. Prescribed drugs, what your doctor prescribes for you, is now the 3rd most common cause of death after heart disease and cancer. We have a real problem with over-medication. And he says again that what we need to do, that we need to find, these drug companies need to be fined so much that they risk going bankrupt. So he published something revealing that most of the top 10 drug companies across the world in the last 10, 15 years have been found guilty of corporate crime. And one drug company actually was ordered to pay $3 billion worth in fines for illegal marketing of drugs, hiding data on harms, manipulation of results. But they were paid this fine of $3 billion, but during the period covered by the settlement, they made $25 billion in profit. So he says, if crime pays, you commit more crime. So the sanctions are not good enough. And this is something that's going on, but the public need to know this. This is not acceptable. We need to strengthen the regulations on this. We need to stop this happening. And in terms of new drugs coming out, people keep hearing about new drugs. Of about 667 new drugs approved by the FDA, Food and Drug Administration in the US, over a 10-year period, only 11% were actually found to be truly innovative, better than the previous drug. So they produce a new drug, they change a few molecules around, it's essentially the same drug, they market it, get a patent on it, make more money, and by the time people have worked out there's no different from the previous drug, the cheaper drug, they move on to the next one. So there's so much waste going on as well. Now, again, I'm not here to try and just cause controversy for the sake of it. I'm here to speak to you because this is a real problem, and a lot of different people from various, a lot of honest, good people with great authority realize this is a big problem as well, what I'm talking to you about today. The former editor of the New England Journal of Medicine, this is considered the number one impact medical journal in the world. She said, after she retired, it is no longer possible to trust much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. Wow. Richard Horton, editor of The Lancet, reported on a meeting he had with some distinguished academics And he said in an article, possibly half of the published literature is basically false. Possibly half of the published literature is false. The editor of The Lancet. With it?
Hello? KL? Corolla car, Altis. ആരെങ്കിലും ഉണ്ടെങ്കിൽ ഒന്ന് മാറ്റി കൊടുക്കണേ. Corolla 65D99. Corolla. Please.
Thanks. Yeah, you wanted me to go along though, yeah. Okay, so I'll carry on. Okay, right. Let's talk about obesity. Let's move on to the lifestyle. Let's talk about sugar. Okay, some of you have probably been waiting for this. A journalist asked me yesterday about why I got involved in all of this. Where does this come from? Again, my motivation is working in this several years. There was more and more people coming in with obesity-related problems, chronic conditions, more unhappiness, more stress on the system, more difficult to manage. We have a National Health Service in the UK. Everybody has access to healthcare, and it's free, which I believe is a great thing. And I would see more and more pressure on the system. And I myself went into a kind of investigate what was going on. This is about 10 years ago as a junior doctor. You know, why have we got this obesity problem? What's going on? What can we do to stop it? And this is really the problem now. In the UK, 2/3, so 60% of the adult population are overweight or obese, and 1 in 3 children by the age of 11 are overweight or obese. You know, and it's costing a lot of money, billions of pounds. Now, and I think in India this is also true to some extent, is that the root cause of the problem is really the food environment. We have moved away from traditional diets in many ways, and we're eating a lot of ultra-processed food that comes in packets, okay? High sugar, high carbohydrate, palatable, addictive foods. Everywhere you go in the UK, you cannot avoid this, you know, whether it's going to the petrol station, whether it's on the street, high street, even health clubs and gyms are selling this sort of sugary snacks, sugary drinks. But for me, the real scandal was that even our hospitals had become a branding opportunity for the junk food industry. You know, how does this make sense? We're supposed to be promoting good health and we're selling junk food in the hospital grounds. Doesn't make any sense. We might as well be selling cigarettes as well to patients in the hospital. We might as well have cigarettes. Why not? It's nonsense. And if we're going to really tackle this problem, then we need to really concentrate on the socio-economic environment, but also changing the food environment to make it the default choice healthier. And that's what happened with tobacco. We got tobacco consumption down in the Western world because of regulations, taxing cigarettes, making them more expensive, banning tobacco advertising. We applied the same principles to food. That will then reduce the availability, the affordability, and the acceptability of these junk foods, which people haven't really, I think, caught on enough on in India as how damaging they are. So I'll just move on. Sugar. I mean, I've been known as quite a prominent campaigner in the UK, really highlighting the harms of too much sugar consumption, which has become a major issue in the last 10 to 15 years. And John Yudkin, I talked about Ansel Keys. At the time, Professor Ansel Keys was saying saturated fat was a problem, cause of heart disease. John Yudkin, a British physician, he said that it was sugar that was the problem. We need to really reduce our sugar consumption. That is what's driving heart disease. But John Yudkin didn't have the power that Ansel Keys had. He didn't have the financial backing. He didn't have the political prowess. And unfortunately, you know, he died an unhappy man. His warnings were not taken seriously. The sugar industry launched a PR campaign to say sugar is healthy. And they didn't like what he had to say. They tried to stop his work. They interfered with his research and his publication. And he was really hung out to dry. And he writes about this in his book, Pure, White and Deadly, in 1972. And they also funded Ansel Keys, who proposed that saturated fat was the primary cause. And the food industry very successfully, with their PR, successfully discredited the case against sugar, and Yudkin died in 1995. And his warnings were no longer taken seriously until this man comes along. Sorry. Professor Robert Lustig. So he's a pediatrician in America. He's become a very good friend of mine. And he gives a talk in San Francisco, in University of California, San Francisco, which on YouTube has now reached 8 million. There, when I did the slide years ago, it was 4.8. It's now 8 million views about how sugar is toxic. And he writes a commentary in Nature. He gets a lot of press. And I read this and I thought, this is really interesting. And I started looking at the research and verifying it myself. And it made complete sense to me that really the sugar consumption was the issue that was driving the problem of obesity, type 2 diabetes, and certainly a big risk factor for heart disease. But I think what we need to understand is that a lot of us grew up thinking we need sugar for energy, but sugar in its pure form has no nutritional value. It doesn't provide any nourishment to the body whatsoever. It is pure excess energy we don't need, and you don't need any carbohydrate. We can survive without it. And then we had studies showing there was a very good link between sugar consumption and obesity. Again, it's the most common cause of, it's in fact one of the only substances we ingest that's directly toxic to tooth enamel. And in the UK, it's, chronic pain in children is the most common cause is tooth decay caused by sugar. So what happens is when you have fructose, the fructose component of sugar, so sugar, sucrose, table sugar, is basically glucose and fructose, 50% of each. If you have this in excess, over time it contributes to insulin resistance, we've talked about already, or the metabolic syndrome. Now, in India, metabolic syndrome is the real issue because a lot of people in India get type 2 diabetes and insulin resistant by not being overweight. I say there's no such thing as a healthy weight. Probably half of Indians with type 2 diabetes are not overweight. They're not overweight. They have a normal BMI, but it's the belly fat. That's the problem. The excess belly fat, the adipose tissue that develops around the organs in the abdominal cavity, the liver, the pancreas, this is the problem. Now, how do we define metabolic syndrome? Why is it important? Most people now admitted with heart attacks have metabolic syndrome. We talked about insulin resistance. We weren't targeting it. It is that. The data's there. Most people have insulin resistance. And that metabolic syndrome definition is if you have any three of these five: increased waist circumference, increased blood triglycerides, low HDL cholesterol, high blood pressure, and impaired glucose tolerance. Okay, so pre-diabetes essentially, or type 2 diabetes. And this is what Robert Lustig's slide from that he shared with me, is that if you look at this in America, I mean, it's a crude slide, is that the real problem is this metabolic syndrome. Up to 40% of people who suffer from the metabolic syndrome have a normal body mass index. Now, for a long time, companies such as Coca-Cola have been giving us fictitious information. Because targeting obesity, they say, is about calories. It's about how much you consume in calories. Beating obesity, they say, Coca-Cola, will take action by all of us based upon one simple common sense fact. All calories count, no matter where they come from, including Coca-Cola and everything else with calories. But that doesn't make biological sense because calories from different foods are going to have different effects on the body. Some are going to have fiber. Almonds are going to have fiber. You're going to have protein. You're going to have fat. You're going to have fructose. They're all going to have a different effect. The same amount of calories from each of those food products is going to have a different nutritional value, different effect on blood glucose, different effect on inflammatory pathways, different effect on gut microbiome. All calories are not the same. But the industry wanted us to believe it. That's why we were calorie counting. It's about calorie-controlled diet. And this study done by Lustig and colleagues in Stanford actually really showed that in the environment, they tried to see what in the food environment would predict type 2 diabetes increase in the population. Okay? And they did this analysis and they found that for every excess 150 calories of sugar that was available for consumption, which is typical of a can of cola. So one can of cola is about 150 calories of sugar, 8.5 teaspoons. For every excess that was consumed above one's normal quota, there was an 11-fold increase in the prevalence of type 2 diabetes, 11-fold increase, independent of weight, independent of activity levels. So even if you are slim and you do exercise, even if you are slim and you do exercise, but you're consuming too much sugar, you are very likely increasing your risk of type 2 diabetes. And this was a big, important study. I saw this and I thought, okay, I need to write about this now again. In fact, this was before the saturated fat piece in the BMJ. The other thing is the marketing. Again, people are being misled, right? So in the UK, there was guidance on how much sugar you should consume, and you pick up a can of cola, Coca-Cola, which has 8.5 teaspoons in, and the American Heart Association had come out and suggested no more than 6 teaspoons should be consumed a day, maximum. One can of Coke has 8.5 teaspoons, but on the label, it's a little bit blurred there, it says this represents 36% of your daily sugar allowance. 36%. So what they're saying is we should be consuming, as part of a healthy diet, 22.5 teaspoons of sugar a day. Can you believe it? And this is coming on the labeling in the products in Europe, in the UK. So people are buying these products thinking it's fine, but it doesn't fit with the science. It doesn't make sense. So lots of things the food industry do to try and deceive us, and they focus on personal responsibility. They say it's about lack of exercise. But when you think about progress that we made with tackling tobacco, it took 50 years from when the first links between smoking and lung cancer were published in the British Medical Journal before we had any effective regulation in the developed world, and obviously now moving to the developing world, because the tobacco industry were very powerful and they adopted a corporate strategy of planting doubt, denying that cigarettes were harmful, confusing the public, and then even buying the loyalty of scientists. And the extent of that denial even goes to 1994. 1994, the CEOs of every major tobacco firm went in front of US Congress and swore under oath they did not believe nicotine was addictive or smoking caused lung cancer. In 1994, can you believe that? So I basically wrote an article on the BMJ. This got press release. I said, I need to get this information out in the public. I'm a public health advocate. People need to know this. It was picked up by BBC News. I was there on BBC Breakfast, which is the most watched channel in the morning in the UK. And I said, there's a problem with the advice on sugar. We need to change this because people are consuming too much sugar and they think it's not harmful. It's very harmful, and we need to get this sorted. And the labeling is wrong. It's misleading people. And in fact, the guy who was interviewing me said at the end that we invited organizations and companies who are associated with sugary drinks and supermarkets and sugary foods to discuss this with Dr. Malhotra, to debate with me. Unfortunately, all of them were unavailable. They weren't able to debate me because I knew that they would put them in a very bad spot. Then we launched an organization with a number of people called Action on Sugar, and we did a lot of campaigning, a lot of stuff in the media. All of the media got involved. Every single newspaper was involved. Every journalist was onto looking at sugar labeling, how many products had, sugar in them, and how many teaspoons of sugar. And people were reading these articles thinking, wow, this low-fat healthy yogurt, 6 teaspoons, or something having, something from a coffee store, one of these frappe, one of these lattes and caramel, this and that. 20 teaspoons of sugar. People are not told. Can you believe it? Having in one helping 20 teaspoons of sugar. So this was all launched, and eventually we did a press release and we said, listen, we need action now. A group of scientists have got together. We think there should be a reduction in sugar in the population. We launched Action on Sugar, and it was called, it hit the front page of the Daily Mail in 2014, Sugar is the New Tobacco. There was a great headline. That really then resonated with the public. We know tobacco is back. Sugar is now the new tobacco. And it got international coverage. I think it was definitely picked up in India as well. I think I spoke to a Times of India journalist at the time. But yeah, it got a lot of impact. And that was really what really helped raise the awareness for the public and for the politicians that they needed to act as well. I'll move on from that. So the major issue now is that our consumption of ultra-processed food is dominating the diet. Ultra-processed food there's a classification which I'll simplify for you, is if it comes from a packet, if it comes out of a packet, a packaged food, and it has 5 or more ingredients. If you pick something up, you're not sure whether it's healthy. One way to know, just count the ingredients. So those ingredients still have this and this and this. If there's more than 5, it's ultra processed. It should be eaten rarely or as a treat or something once a week on the weekend. Half of the diet now in the UK is ultra processed food. Meals coming out of a package, ready meals, reheating stuff. Potato chips, crisps, candy bars, whatever, all of this stuff. Ultra processed food, half of the diet. Now if you break that down, what is in the ultra processed food? Most of it is not fat. Only 2% is coming from fat. Most of it, I calculated 77% is coming from sugar and starch. Sugary, ultra-processed fruit and vegetables in a tin, a lot of sugar, starchy foods, breakfast cereals, sugary drinks, sugary products. So most of it is coming from, it's not fat. We shouldn't be demonizing. I mean, clearly, it's too much. Because it's cheap, it's highly palatable, it's addictive. It works with the food industry. They get high profit margin. They sell it, and we get sick. Let me move on. And there's even an environmental problem also with the drug companies in terms of the waste that that gets into the water supply is now causing a big problem from all the drugs we're consuming that's now being excreted into the water supply, then comes back in. It's causing problems. A lot of fish are dying because of this issue of too many drugs. So one of the things I did on my journey is I went to a southern Italian village in Italy called Pioppi. And Pioppi is considered one of the world's healthiest villages. Their average life expectancy is 89, 90. They're all healthy into old age. Many people live over the age of 100. They're not taking any pills, or very few. And we wanted to discover what were the secrets of this village, and how could we marry those secrets of the way these people live with the latest independent, or as independent as you can get, research to try and give people a plan, individuals a plan about how they should live. What does it mean to live a healthy life? How can people be healthier? So I went with the chap on the far left there, Donal O'Neill. He's a former international athlete, and he was my co-author on the book, The Pioppi Diet. And we also did a film called The Big Fat Fix, and he co-produced that with me. And we went to this village, and we produced this book, which is now, I'm delighted to share, as an international bestseller. Published in the UK about a year and a half ago. And we wanted to bust some myths, and I give a detailed explanation about cholesterol, saturated fat, sugar, the things I've talked about today, type 2 diabetes. And we basically, some of the myths we busted, as you've already heard, is eating fat does not make you fat. Cholesterol can be good for you, and if you're over 60, bad cholesterol protects you from an early death. Physical activity and obesity is a myth. So physical activity is very good for health. But if you want to lose weight, diet is the thing you need to do. Activity has many benefits, but weight loss is not one of them. It's going to be diet, diet, diet. And you can't outrun a bad diet. And actually, probably most importantly, is that dietary changes, changing one's diet, is more powerful than any drug. And it comes without side effects, and the effects are rapid. So 2017, myself and 2 eminent cardiologists, in fact the editor of JAMA Internal Medicine, Professor Rita Redberg, and Pascal Meyer, we published an editorial in British Journal of Sports Medicine, which for any BMJ journal was the most read that year. And we wanted to shift the understanding of heart disease to say, and this is a diagram from that peer-reviewed article, is actually what we're dealing with heart disease. What we need to be doing is concentrating on insulin resistance and chronic inflammation, which is driven by excess fructose, refined carbohydrate consumption, and this causes also a problem with the cholesterol profile. But the best way to really combat it, and of course I've said high-fat Mediterranean diet here based upon studies we have available, but you can do this in the Indian context. Essentially, it's a healthy diet which is low in processed carbohydrates and has nuts, for example, and full-fat dairy in there. You combine that dietary approach with regular activity. Just 22 minutes a day of brisk walking is very beneficial. Stress reduction. I think that you're going to hear in the next few years a lot about the importance of stress and its role. And meditation, I think, is a very powerful tool to not just improve people's health in the short term in terms of sense of well-being, but there seems to be data suggesting that it reduces inflammation in the body as well. So I try every day. First thing I do when I wake up in the morning is I do 30 minutes of meditation every day now. And I felt a lot better because of it. You know, I feel, and I prescribe. I think that in modern addictions, we're not also social interaction. You know, one of the best markers of quality of good health and longevity also is meaningful
Check
strong
this.
community relationships.
Hey.
Meaningful relationships, friends, family, your sense of community is very important for good health. We seem to be forgetting about a lot of that. You know, it's protective. Having people around us, people we care for, people who care for us, is protective. So we have to think about that. And smoking cessation clearly is still, although in the Western world it's reduced dramatically, I think in India it's still a big problem. Smoking is still a big, big problem. This is just one example of somebody on Facebook, a Malaysian chap, out of the blue. He'd read my work, and he posted that, having read my work in Jason Fung, he said, I told my doctors, he said he had metabolic syndrome, he had high blood pressure, he had high BMI. He said, I told my doctors I refuse to take metformin and statin. And he says, today, following the advice of two great God-sent doctors, Dr. Aseem and Dr. Fung, I have totally reversed my metabolic syndrome. And he did this very quickly within a few months. His HbA1c is now normal, and he's low carb. His blood pressure is normalized. His fatty liver has got normal. I mean, this stuff works. It's not just anecdote, because there is good extensive data there around this, and when you look at the totality of evidence, that this works. Some really good programs going on in the US and the UK. In the UK, diabetes.co.uk, an independent organization. They don't have any association with food industry or drug industry. So they have an online program, and they get people on this low-carb diet, and they've reported very good results. They have 285,000 members now. And with the engagement, they noticed significant reduction, 60% less people taking insulin, going low-carb after a year. At least 40% eliminate one or more medications. Average weight loss is 7.4 kilograms. And they reduced their HbA1c by 39%, which is really quite extraordinary. It's really good. Some will obviously do more and some a little bit less, but it's certainly very powerful. And Virta Health as well, they published a study showing that 60% of patients in this study had obesity, actually predominantly type 2 diabetes. They reversed their diabetes within a year. 60% sent their diabetes into remission from a low carbohydrate program. So I'm just about to finish up. Thank you for being very patient with me. I'm just last couple of slides now. So if you remember at the beginning, we talked about numbers needed to treat. Okay? You know, the benefit of a drug, one in whatever for that individual in preventing a death. So let's just look at common treatments for heart disease. Looking at just at death, okay, reducing death. That's, for a lot of people, that's the most important, death rather than anything else. So if you have a heart attack and you take aspirin every day for 5 years, there's a 1 in 100 chance aspirin will save your life. 1%. According to the data, if you've had a heart attack or heart disease, 1 in 83 mortality benefit will benefit from a statin. Over 5 years, 1 in 83. We know that if you're low risk, if you don't have heart disease, there's no benefit. Infinity means there's no benefit. You're not going to live any longer from taking a statin or aspirin. Now, if you have a stent during a heart attack, yes, 1 in 40 chance the stent procedure itself will save your life. 1 in 40. Now, some people are surprised by that. They probably thought it would be more, but no. With everything else we do, with the medicines, with the care, with getting people to hospital, all these things impact. And a lot of people have heart attacks and survive without any treatment at all. So what will the stent add? About 1 in 40 chance of reducing your death, of saving your life. We know that stents at any other time, if you don't have heart disease, if you have heart disease but haven't had a heart attack, again, no benefit. But, sorry, we're giving it away. The most powerful intervention we have, based upon randomized controlled trial data, after a heart attack, the most powerful intervention from the trials that are there, that have been conducted, the research we have, Mediterranean diet. Almost 3 times more powerful than taking a statin and comes without side effects. But most people don't know that. We've kept this information away from people. And if we keep this information away, people are not empowered to make choices that are going to be best for them. And really, we need to change that now in healthcare. And if we change that, we have more transparency, we'll be able to help more people, we'll have much more quality healthcare, we'll have more ethical care, more sustainable care. I'll finish with a quote from Christian Barnard, who says that basically he was the world's He pioneered heart transplantation, did the world's first heart transplant, South African surgeon. And he said, I've saved the lives of 150 people with heart transplantations. If I'd focused on preventative medicine earlier, I would have saved 150 million. It turns out that lifestyle is that medicine. Thank you very much.
Okay. If you have any doubts, we can clear. ഉണ്ടെങ്കിൽ മാത്രം ചോദിക്കണമെന്ന് കരുതി ചോദിക്കണമെന്നില്ല. കാരണം നമ്മുടെ സമയം 1 മണി, ലഞ്ച് ബ്രേക്കിൻ്റെ സമയമാണ്. അത്യാവശ്യമായിട്ട് ആർക്കെങ്കിലും ചോദിക്കണമെന്നുണ്ടെങ്കിൽ ഇനി മലയാളത്തിലായാൽ പോലും നമുക്ക് അത് ചോദിക്കാവുന്നതാണ്. ഇറ്റ് ഷുഡ് ബി ജെന്യുവിൻ. നിരവധി ക്വസ്റ്റ്യൻ ആൻസർ സെഷനുകൾ നമ്മൾ കഴിഞ്ഞതാണ്. ഇതിനു മുമ്പും പല ആളുകളും ക്ലിയർ ചെയ്തതാണ്. ഇദ്ദേഹത്തിൻ്റെ വിലപ്പെട്ട സമയം അറിഞ്ഞുകൊണ്ട് വളരെ റെലവൻ്റ് ആയിട്ടുള്ള ക്വസ്റ്റ്യൻ ആണെങ്കിൽ ഓക്കെ. Is there any difference between LCHF and paleo?
Is there a difference?
Difference if there is?
There's not really a major difference. They're quite similar. I think with paleo, they exclude dairy and they allow a bit of honey. But they're quite similar in a sense. LCHF is a much more broad term because LCHF then incorporates many different cultures and different diets. But no, there's not a lot of difference, no.
ഇല്ലാന്ന് തന്നെ അറിയണം. മറ്റേത് ഒന്നുകൂടി സ്ട്രിക്റ്റ് ആണ് കീറ്റോ ഡയറ്റ് എന്ന് പറയുമ്പോൾ. മറ്റേ പാലിയോ എന്ന് പറയുമ്പോൾ ചെറിയ വേരിയേഷൻസ് ഒക്കെ ഉണ്ട്. പാലിയോനെ പറ്റി വിശദമായിട്ട് നമ്മളെ ഉച്ചയ്ക്ക് ശേഷം നമ്മളെ ശങ്കർജി സംസാരിക്കുന്നതാണ്. LCHF കുറിച്ചാണ് ഇപ്പോൾ പറഞ്ഞിട്ടുള്ളത്.
ഞാനൊരു ആർട്ട് പേഷ്യൻ്റാണ്. എനിക്ക് ആൻജിയോപ്ലാസ്റ്റി കഴിഞ്ഞതാണ്. പക്ഷേ എനിക്കതുകൊണ്ട് ഒരു ബെനിഫിറ്റും ഉണ്ടായിട്ടില്ല. ഇപ്പോൾ ഞാൻ മരുന്ന് കഴിക്കുന്നുണ്ട്, സ്റ്റാറ്റിൻ ഒഴിച്ചുള്ള ബാക്കി മരുന്ന് കഴിക്കുന്നുണ്ട്. ഇത് കണ്ടിന്യൂ ചെയ്യണോ അല്ലാതെ വേറെ വല്ല ട്രീറ്റ്മെൻറ്റ് ചെയ്യണോ? ഞാൻ പിന്നെ ഇത് ഡയറ്റിൽ സ്ട്രിക്റ്റ് ആണ്.
ഒന്നും കൂടി എന്താണ് എക്സാക്റ്റ് എന്താണ്?
എക്സാക്റ്റ് എനിക്കൊരു ബ്ലോക്ക് ഉണ്ടായിരുന്നു. അതൊരു ആൻജിയോപ്ലാസ്റ്റി കഴിഞ്ഞതാണ്. അതുകൊണ്ട് എനിക്കൊരു ബെനിഫിറ്റും തോന്നിയില്ല. ഞാനിപ്പോൾ ഡയറ്റ് തുടങ്ങിയതുകൊണ്ട് എനിക്ക് കുറച്ച് ബെനിഫിറ്റ് ഉണ്ട്. പക്ഷേ ഞാൻ മരുന്ന് സ്റ്റാറ്റിൻ ഒഴിച്ചുള്ള ബാക്കി 2 കോൺകോറും ക്ലോപ്പിലെറ്റും ആസ്പിരിനും കഴിച്ചുകൊണ്ടിരിക്കുന്നുണ്ട്. അത് ഞാൻ എന്താ കണ്ടിന്യൂ ചെയ്യണം. എനിക്കതുകൊണ്ട് വലിയ ഗുണം തോന്നണില്ല. എങ്കിലും ഈ ഡയറ്റ് കൊണ്ടാണ് കുറച്ച് മെച്ചമുണ്ടായത്.
So, can you hear me? Yeah. It would be wrong of me to contradict your doctor's advice. So I think, if you're not sure, then have a conversation with your doctor about the medications you're taking. If the standard approach to people with heart disease, even myself, is we put them on aspirin, we put them on a statin. And if there's a problem or a side effect issue, then we have a discussion with the patient. We can change the dose or give an alternative drug. So I would carry on for now. But if you've got any questions with your doctor, you need to make sure that he explains it to you rather than just stopping. I wouldn't encourage people just to stop their pills unnecessarily without talking to their doctor. That wouldn't be the right thing to do because we could cause harm unnecessarily and people don't fully know. I mean, the case I showed of Tony Royal was quite unusual and he was very informed and empowered himself. But I think, you should talk to your doctor.
ഇതൊരു കൺസൾട്ടേഷൻ അല്ല കേട്ടോ. അപ്പോൾ അങ്ങനത്തെ ക്വസ്റ്റ്യൻസ് ചോദിക്കണ്ട. Please don't put him on the spot. This is not a consultation.
And also, because I'm not your doctor, I can't give you individual advice. It would be unethical for me to comment on your individual case, but I can discuss general points. Sorry, I didn't quite... yeah. Yeah, no, so there's... No, so I'm just... It could be statin, aspirin, or statins. That's what it means.
Hello.
No. It means it's just either of them. If you're low, it doesn't have any benefit. If you're low risk of heart disease, aspirin and statins have no benefit on terms of death rates. You're not going to live any day longer. That's the point I'm making.
Hello. Sir, good evening.
Yeah, a good question. Yeah, if you're over 60, I don't worry about LDL. I think I wouldn't worry about LDL for most people. I would concentrate on triglycerides, HDL, insulin-resistant syndrome. Interestingly, LDL does seem to sometimes get lower anyway, but because some of the LDL is also increased by sugar. But I wouldn't focus on the prime. A lot of doctors look at it and they focus just LDL. LDL is high, let's get the LDL, and ignore everything else. That's a wrong approach.
Good evening, sir.
Yeah, his cholesterol, his total cholesterol went high, but his ratio got better. Remember I said what's the predictor? Even if you look in America and the UK, they have risk calculators to calculate heart disease risk. They don't use total cholesterol. They do total cholesterol divided by HDL, the good cholesterol. That was, his total cholesterol gone up, but the HDL had gone up even more, so the ratio was better.
What about the LDLs? But you know, people usually say that those who are adapting the LCHF diet,
Yeah.
cholesterol level never come normal. It will be slightly.
Yeah, it's a good question. So a lot of people, their profile gets better, but some people are hyper responders, and their cholesterol does go very high. I've seen a few patients like that. There is a study showing that we don't think there's any problem there, because even at heart disease, you look at establishment of heart disease, the biggest predictor is triglycerides and HDL. But it's a difficult one. The honest answer is in these patients, in those patients that have an LDL that goes up, and it's a small minority, we don't know whether it's going to cause harm. We don't really know. But my personal view is that other profile, everything else gets better. Overall, they're actually much healthier and better. And if those people, if there is a bit of a concern, then those people can try a low-dose statin. I mean, I think the thing about statins is the side effects seem to be much less likely when you're on a lower dose, but a lot of doctors are prescribing the highest dose, and that's also a problem. Yeah.
Good evening, sir.
Yeah, it's part of the cholesterol profile, yeah. I mean, if triglycerides are high, then your total cholesterol can go up.
ടോട്ടൽ കൊളസ്ട്രോൾ എന്ന് പറഞ്ഞാൽ LDL, HDL, VLDL മൂന്നും കൂടി കൂടിയതാണ്. VLDL എന്ന് പറഞ്ഞാൽ 20% of triglycerides.
One of the problems is often in the reports they don't put the triglycerides in. So if you're getting a cholesterol profile done, you should definitely ask for triglycerides. It has to be independently looked at. Yeah, it's not correlated with total cholesterol, yes.
Good evening, sir. Sir, LCHF മരുന്ന് കമ്പനികൾ വെറുതെ ഇരിക്കുമോ? എന്താണ് കരുതൽ?
No. There's no known problem with high cholesterol hyperresponders as far as we know.
Yeah, last one here.
Hello.
Yeah. There'll be a video shared on YouTube. So.
Sir, really thankful. It's a very informative class. Okay. What about eating fruits in LCHF diet?
Some people are happy to have no fruits and have more vegetables. I think if you're going to go for the fruits, I would say go for the low sugar fruits, berries, for example. It also depends on how active you are. If you're quite active, you can probably get away and still have, by having a little bit of fruit and being low carb. And it also depends where you are, where you're starting from, etc. I personally, I practice what I preach. I follow, a relatively low carb diet. I'm not ketogenic, but I'm low carb. But I'm also quite active. So I will usually have probably 2 to 3 fruits a day, in and around the time I exercise. But I'm not against, whole fruit is not really the major issue, it's juice. Juice should be avoided because it's a very high concentration of sugar.
Can we get all nutrients from vegetables?
Ooh, can you get all nutrients from vegetables? I think Dr. Huda will tell you a bit about that later, but I think it's difficult to get enough protein. It can be challenging, and certainly B12 deficiency seems to be a problem as well. So I think it's more challenging. I think you probably could in theory. I think one of the issues with vegetarianism and veganism is that there's a lot of nutritional deficiencies that happen, and they're more likely to happen if people are eating more starch and sugar and less of the veggies. So Yeah, I think you can get most of it from, you can have a healthy vegetarian diet. If you eat eggs, is also easier.
Good afternoon, sir. Sir, there is a misconception among people that we can have as much fatty food we can have. So what will happen if we consume more than what is recommended in the diet? Fat?
Yeah, the advice we give normally, I mean, most people are sensible. I mean, if you overdose on anything, it's going to cause you a problem. If you proactively overdose on something, it's going to cause you a problem. But 99.9% of people don't do that. I mean, they follow the plan about eating till you're full, you know, get your nutrients, get your balance right. So I haven't seen any harm as such. But in theory, yes, it could be harmful, yes, in theory. But in the practical terms, it doesn't happen.
So actually, sir, excuse me. My name is Farzin. Actually, I'm asking for that. If you are doing long-term LCHF, is there any problem for pancreas? Means making insulin, because inflammation means normal inflammation also need this insulin. That's why we are talking about it like this. Then is there any problem for long-term LCHF for this insulin making production, or inactive pancreas will be occur or not? Like that?
No, you won't have an inactive pancreas. I don't think that. There's always going to be some production of insulin. It's just much lower. We don't have any data to suggest any harm. And certainly in the short-term studies, all of the risk factors get better. So listen, as I said, medicine is not an exact science. Sometimes things can be thrown at us that don't make sense. But it doesn't seem to make any biological sense. If all the metabolic risk factors get better, blood pressure gets better, glucose control gets better, insulin resistance gets better, inflammation gets better, how can that then have a long-term negative effect? So and there is no data to suggest that there's harm. There's been also some misinformation out there suggesting that low carb also is low fiber, and that's also false. In fact, actually, you know, a well-planned low-carb diet in general is actually quite high fiber, much higher fiber than the standard low-fat diet, because people end up actually eating more vegetables.
Hello. I'm on a BP drug for more than 15, 16 years, and a few years from that, I started developing diabetics, and I'm now taking a BP tablet and metformin in the morning and the evening. Am I safe by going into these keto LCHF diet and stopping both the medicines?
I wouldn't. So yes, it's safe, but actually often people's, let's say, glucose control, metformin shouldn't be a problem. Blood pressure, you have to be a bit careful. If you lower your blood pressure and you're still taking the pill, your blood pressure may go too low. So I would just monitor. No, it wouldn't go up. Actually, no. Are you asking me whether it's safe to go low carb if you're high BP? You're on treatment. What's going to happen if you go low carb or keto is often people's blood pressure lowers. So if you're on treatment for blood pressure and it's controlled, you lower it further. In theory, what can happen is you're overdosing on the medication you don't need. Yeah? So that's one of the issues. But no, I mean, it's a good thing. Because I see patients, in fact, I remember one chap came to see me, he'd been on 3 blood pressure pills for 10 years. In 3 months of going low carb, he came off all his pills. His blood pressure became normal.
Okay, last question.
So many restaurants started keto food. We can follow that?
Listen, yeah, of course. We live in a capitalist society, and there's money to be made from these things. You know, as Robert Lustig said to me, he said, Aseem, I have no problem people making money doing the right thing. I have a problem people making money doing the wrong thing. I think with the keto stuff, yeah, I'm a little bit, you know, if there's a keto bar or something, or people's taking occasionally, these things sometimes are, again, ultra-processed. So I want the concept of us eating real food, as opposed to, and minimizing these ultra-processed packaged food to be there. If you're having an ultra-processed diet of keto, then I think that's probably going to cause you more harm, probably. Okay. Thank you.
Okay, thank you. Thank you, doctor. നമ്മുടെ ഫോർനൂൺ സെഷൻ ഇവിടെ അവസാനിക്കുകയാണ്.